Welcome to As a Woman, Fertility Hormones and Beyond. I'm your host, Dr. Natalie Crawford, and I am a board-certified OBGYN and fertility physician, and also co-founder of Fora Fertility in Austin, Texas. Each week on this podcast, I discuss health and fertility and how they relate to your true self. Become a part of the community of collaboration that amplifies others as a woman. I hope you enjoy the episode. Welcome to the As a Woman podcast. I'm your host, Dr. Natalie Crawford, and today we are answering your fertility questions. I'm a board-certified OBGYN and REI, so I am a fertility doctor, and it is my personal mission to help you understand your body better so that you can make the choices that are right for you. Whether it's to have kids now, in the future, or never, you deserve to understand your body because your hormones, your period, your fertility, it's a sign of your overall health, and you deserve to be your healthiest self. This podcast exists just to help you get those answers. So I would love if you would subscribe and follow along. You can always check out nataliecrawfordmd.com on the website, where we have tons of other resources, and you can sign up for the newsletter. On the newsletter, I'm answering some of your fertility questions and updating you on fertility in the news and general fun things like recipes and updates. I also love to answer your questions on Instagram. You can ask questions at nataliecrawfordmd every Monday, and you will find some questions are answered right there. Some questions will be answered right here at the end of podcast episodes, and some questions will be answered in the newsletter. This is a voicemail episode, my absolute favorite. This is for those of you that have questions so pressing that you want to call and leave them so that I can answer them. If I could, this would be the entire show. So call and leave your questions so we can get to them. 657-229-3672. Again, that number is 657-229-3672. Today's episode, we are talking all about natural fertility, fertility testing, and basic information that you should understand about your reproduction. So thank you so much for asking your questions, and we are going to go ahead and get started now.
Hi, Dr. Crawford. My name is Christy, and I have a question about my AMH. A quick backstory about me. I'm 35 and a half now. I had 2 chemical pregnancies at 32 and then a successful pregnancy at 33. And then we've been struggling a lot to get pregnant with our second. I had a missed miscarriage at 8.5 weeks in August, and then another chemical in October. So my OBGYN tested my AMH in November, and that came back at a 1.21. However, we were referred to an REI, and they just, did all the testing, and my AMH came back at a 0.7. And it's only been 3 months since the first test. So I'm wondering why that is, why the dramatic drop, what does that mean? And, all my other blood work came back normal, and so did my HSG. And they think that I have an egg quality issue. So we're going to go the IVF route, and they expect I'll probably get around 7 eggs based off of my 0.7 AMH number, although who knows how many of those eggs will survive and be normal because they think it's an egg quality issue, and likely less than 50% of my eggs are normal. So I'm just curious what your thoughts are, and if you could explain that number discrepancy in the AMH. Thank you so much for everything you do. And you've been such a comfort to me these past few months in our struggles, and I know a comfort to so many others. Thank you again. Bye.
All right. Well, thank you so much for sharing. And I just want to start by saying I'm so sorry for everything you're going through. I know that loss and infertility and all of these results, it just makes everything honestly really overwhelming. So sending you a huge virtual hug. Your question about AMH is so valid. This is such a common question that I get, and it just goes to really understanding how our ovaries work and what AMH is. So this is my favorite analogy. If you can imagine that inside your ovary is a vault where all your eggs are kept, you're born with all the eggs you're ever going to have, about 6 to 7 million when you're a 5-month baby inside your mom. At birth, that's going to be about 1 to 2 million. Every single month, you lose a group of eggs, even before you start having a period. A group of eggs all come out of the vault. Now, all of those years before you start your period, they just die. The eggs just die. Once you go through puberty, the brain turns on, and now the brain is going to send out FSH, or follicle stimulating hormone. FSH works to stimulate a follicle to grow. As that follicle grows, the egg inside of it grows and matures because there's one egg inside each follicle. That is the egg that then ovulates and the rest of the eggs die. Next month, another group. There's nothing you can do to stop this process of egg loss. If you're pregnant, you're still losing eggs, same rate. If you are on birth control pills, still losing eggs at the same rate. So that process is not changing based on what you do. When we think about this though, what's very interesting is the more eggs you have remaining or inside the vault, the more eggs you have coming out of the vault every month. And the fewer eggs you have in the vault, the fewer eggs come out every month. So even though I can't see in the vault and know exactly how many eggs you have, I can evaluate the eggs that are outside the vault. And that's going to give me information so that I can understand at least what category you're in and how many eggs you have. Each egg is surrounded by cells called granulosa cells. And those granulosa cells make a hormone called AMH, or anti-Mullerian hormone. So in its shortest way of thinking about it, the more eggs that you have, the more AMH you're going to have, and the fewer eggs you're going to have, the lower AMH. In reality, AMH is really made by the eggs that are outside the vault or in a line. I like to think about AMH as lasting for about 3 months in your bloodstream. It's not exactly like that, but it helps you understand that AMH is more than a one-time glimpse this month, whereas an antral follicle count, counting the follicles on an ultrasound that you see in a given month, is a one-time glimpse. So these two tests, one is a blood test, one's an ultrasound, even though they are both evaluating ovarian reserve, they're actually doing it in different ways and evaluating different time periods. And I think that's very helpful and why I recommend doing both. What is so crucial to understand? Everybody's born with eggs. Everybody runs out of eggs. Everybody starts with a different number. Everybody runs at a different pace. We all have our own graph, our own slope of the line. However, some people run out of eggs faster and some people run out of eggs a little bit slower. And that's one thing that I think is very interesting. When we check AMH, when we check your follicle count, what we know is that the body is not perfect. So it's not going to send out exactly the same number of eggs every single month. If I use an example at age 35, that I would expect you to have 14 to 16 eggs outside the vault if you fell average. Well, what that means is that if I look at 6 months in a row, I might have 14, then 13, then 16, then 15, then 17, then 12, then 15, then 19, then 17, more than 6 months. But that averages to be in that 14 to 16 range, even though if I saw you on the month where you had 12 eggs, or I saw you on the month where you had 19 eggs, both of those are a 30% swing from what I would call your average, thus very normal, I would get a different AMH value. So this is telling us that your AMH is based on the number of eggs you have in a few month time interval, and it is going to go up and down. If I checked an AMH in every month of everybody, it's going to change. And that's why we don't do that. That's why we don't recommend checking your AMH if you had one recently done. And we don't have a guideline for how soon it should be checked because it gives an idea. Our brains cannot help believe that the drop is linear. Your brain says, oh my gosh, it was 1.31 and now it is 0.7. And if it keeps going at this pathway every 3 months, I'm going to be out of eggs in a year. And that's not the truth. So number one, understand that it's not linear, that probably you've measured two ends of the extreme, and I would bet the truth is somewhere in between. Number two, I would recommend an ultrasound and get an antral follicle count. I know you said your team said your egg count was 7, anticipated based on the AMH, but did they count 7 on ultrasound? That can be helpful information. The last point I want to make is that everybody will tell you, and this is based on very good data, that having a different AMH does not impact your fertility. So having a low AMH does not cause you to have infertility. It's not an etiology of infertility. And we know that monthly pregnancy rates are the same in people regardless of their AMH as long as they are ovulating. That said, what causes somebody to have a low AMH in a younger age range? And some of those things can in fact contribute to infertility. And I find that people with unexplained infertility, a lot of them have a higher probability of having a low AMH than we should see for their age. So to me, this is probably endometriosis, autoimmune disease that's not diagnosed, chronic inflammatory diseases, some type of toxin exposure, smoking cigarettes, something. And maybe we don't know. And maybe it was something your mom was exposed to. Maybe it's genetic. There's some different variables there. But I'm always wondering if there's some piece of the puzzle in these patients who have a lower AMH for their age that is making it harder for them to get pregnant, despite the classic, your AMH doesn't matter as long as you're ovulating. And that would support what your team is saying about egg quality. And I would ask questions or consider, do you have endometriosis, any of the signs or symptoms, or any other autoimmune disease or inflammatory disorder? But I think it's great that you're preparing for IVF, and absolutely, it's the only thing that exceeds our natural chance of getting pregnant. When you do have a lower AMH from your age and you want to have more than one kid, doing IVF is going to get you pregnant not only faster, but also give you the opportunity to save embryos for the future. Realistic expectations are really important because not every egg is fertilized or becomes an embryo or implants. So really making sure that you know some of the logistics about your protocol and why it's being chosen and what your expectations are and how many cycles you might need if everything is average based on your egg count and your family goals, that's going to make the process that much easier for you along the way. All right. Well, that was such a great question. And everybody, I think if you've been around, you know how passionate I am about helping you understand your ovaries, your ovarian reserve, and your AMH. And I'm so thankful that you called and asked the question. We're going to jump into our next question. But before we do, quick reminder that you can call and leave your voicemail at 657-229-3672. And you can also leave questions on Instagram every Monday at nataliecrawfordmd.
Hi, Dr. Crawford. First of all, thank you so much for doing these Q&As. They've been super helpful. My question was, I recently listened to one of your answers about chlamydia and the potential harm that could happen if someone has a chlamydia infection, and you kind of mentioned that about 6% of women have specific complication. I was wondering, in general, if somebody does have a chlamydia infection sometime in their life and they get treated, and since then they've been negative, what signs should they look out for that they should potentially be worried about it? Should everybody just get checked if they've had chlamydia for the different complications that can arise from it? And, you know, should people be worried in general if they've had it? So thank you so much.
All right. So I know that whenever we talk about chlamydia, it does give people a lot of anxiety because you can't go back and rewind the clock. Number one, if you're at that younger stage, wrap it up, wear a condom. It is just not worth it unless you are 100% in a monogamous relationship and you've both been tested. Chlamydia, sexually transmitted diseases, HPV, they cause many more long-term problems in women than men. So the question here is, does chlamydia impact the ability to get pregnant later or the risk of tubal disease, even if it was treated? And I think that that's really important because often people may not have some of the symptoms. That doesn't mean that you don't have the disease or that the disease is not causing problems for you, especially in your upper reproductive organs. So there was a paper published, and this was in BMJ, the British Medical Journal, looking at the relation between chlamydia and pelvic inflammatory disease, ectopic pregnancy, and tubal factor infertility in a Dutch cohort of women who were previously tested for chlamydia in a chlamydia screening trial. So this is looking at people who are just being screened for chlamydia. And there is both a higher risk of pelvic inflammatory disease and tubal factor infertility in people who had tested positive for chlamydia. When it comes to tubal factor infertility specifically, so PID is pelvic inflammatory disease. That is actually when you have an infection that is of the fallopian tubes, of the ovaries, and it is a more serious consequence of chlamydia when it comes to having to be hospitalized or having a pretty bad infection. However, 70% of all chlamydia infections, so let's go over chlamydia stats, over 130 million cases per year, 10 to 30% of women will have one or more episode of chlamydia. 70% of infections are asymptomatic. Many are then not treated. The rate of having ectopic pregnancy after a chlamydia infection is going to be about 3%, and tubal factor infertility about 6%. When it comes to tubal infertility specifically, the rate of having tubal disease is significantly correlated by the age you were when you had your first infection. So if you were younger than 20, you had a higher risk of having tubal disease than if you were over 24. When it comes to that age, what's really interesting, if you look at the CDC data, chlamydia is a reportable disease. So if I get a positive on a test, I have to report it to the state health department. 2/3 of new chlamydia infections occur in people who are age 15 to 24. 1 in 20 sexually active young women under the age of 24 has chlamydia. Treatment, if you get diagnosed with chlamydia, is actually relatively easy if it's not very severe. It's just an antibiotic dose. Very important that you need to treat your partner as well. And then you need to refrain from intercourse until everybody has tested negative. If we look at another study and further data, by age 44, 43% of women will have had at least one chlamydia infection. That being said, the incidence of tubal factor infertility is much lower than that. So that means in population-based studies, the likelihood of having tubal disease from a single chlamydia infection is going to be overall low. However, it does look like the longer it is from infection to treatment, the higher the rate of chlamydia seeding your fallopian tubes, developing PID or pelvic inflammatory disease. And that is going to mean you're going to have a higher risk of having tubal factor infertility. So get tested, get screened. There's no shame to it. Get treated. Protect your own fertility and protect your own health.
Hi, Dr. Crawford. Thanks for being such an excellent resource for so many of us across the country. I had a quick question regarding my light cycle. I had a long history of an IUD for about 10 years, and after coming off the IUD, I've had regular 27-day cycles. However, my menstrual cycle has been extremely light, barely saturating a tampon once a day for about 3 to 4 days. Is this a concern that my endometrial lining is too thin for a successful pregnancy? Thanks so much. I appreciate you. Have a good day.
I really love IUDs when it comes to being an option for contraception. There is so much to love about it when you're trying not to get pregnant. You don't have to think about taking a pill every day. Of course, that's an advantage. And often you will stop having periods. They last for a long time, so it really can be a nice, effective way. One of the biggest complications that I see afterward is that your hormonal-based IUDs are progesterone-based, and that progesterone thins out the endometrial lining. That endometrial lining is so important for you to be able to get pregnant. And the longer it sees progesterone without a reprieve, the harder it is for it to build back up. So I usually tell people that it can be pretty normal to have light periods for about 6 months after your IUD has been removed. If you have no periods, you definitely should go get an evaluation. But if they stay very light and you're wanting to be pregnant, you should probably go see somebody. What can we do about it? Well, sometimes not much. We should check and make sure there's no scar tissue. That's a very rare but potential complication of an IUD. We also might consider, are you making sure you're ovulating, making sure there's no other factors at play like thyroid or prolactin. But sometimes I find that patients need some estrogen, and sometimes it is just an estrogen month or a pulse just to saturate up those receptors and let the endometrium have some really unopposed estrogen time and get nice and thick and fluffy and have a good bleed. And then the problem tends to be resolved more quickly. So if you're not trying to get pregnant and you're saying, hey, my periods are light, but they're regular, am I worried? I'm not worried yet, because it probably just means you need more ovulatory cycles. However, if you're trying to get pregnant or you want to get pregnant soon, I am more concerned. And now I want you to go get evaluated. If you're at the year mark after having an IUD removed and your periods still seem very light, I would go get an evaluation. There are other things that can cause light periods. Like I said, scar tissue, hormonal issues like thyroid, prolactin, potentially having a lower ovarian reserve and ovulating earlier and not growing as thick of a lining. And those are just things that you do not know unless you go and look. So I strongly recommend, if it's gotten to that point, going and getting an evaluation to make sure that there's nothing else going on.
Hi, Natalie. My question is related to IUDs and scarring. So I recently had my Paragard IUD removed, and my new OBGYN mentioned that she could tell I had been dilated when it was placed, which I assume means that I have some scarring on my cervix. So I was wondering how common that is, and I was also wondering if like IUDs are ever correlated to uterine scarring as well or anything like that. So yeah, thanks so much. Bye.
All right. So this is a great question, which we just were mentioning a little bit when it comes to IUDs. This is a Paragard IUD. So this is not a hormonal-based IUD. This is a copper IUD. A copper IUD works totally differently. It actually causes local inflammation inside the uterus. And this inflammation makes it so that sperm and egg can't meet or implant. So it is also a very effective contraceptive device. There are no hormones, so some people like that. They do tend to make your periods heavier, so some people do not like that. Now, having to have your cervix dilated when an IUD is placed is not necessarily that abnormal. Your cervix, especially if you've never had a baby, might be very small and thin. And I use these tiny, tiny catheters to do IUIs and embryo transfers. But the catheter that holds the IUD, which has to go through your cervix and into your uterus, is quite hefty. If you've had an IUD, I have had one. It was not pleasant. It's worse than other things because your cervix is so sensitive. And the IUD, really, if somebody's going to say, hey, name the number one complication from any IUD, it's actually going to be what we call uterine perforation. So poking a hole through the top of the uterus because you're pushing so hard to try to get that catheter through the cervix that you puncture all the way through. The uterus is actually quite small. You can reduce this risk by making sure that the cervix is appropriate size to get the IUD through. And that's the point of dilation. Dilating the cervix just means you take smaller and then slightly go to bigger. We call them sounds or guides. Essentially, you just place this little piece, it's often metal or plastic, right through the cervix, and you go from smaller to bigger, and it just more gradually opens it up just to the right size of the catheter for the IUD. That part typically doesn't hurt that much. Putting the IUD in further does. Everybody's different though, but it is an important step in order to get the IUD in place. Now, does that mean you have scarring because they needed to dilate you? It does not. It might just mean you have a very normal nulliparous, meaning you've not had a baby, cervix. Does that mean that they had uterine issues or something wrong on the inside of your uterus? I would not feel that way either. Now, if your OB can see that your cervix was dilated, I'm not sure what they mean by that. Maybe that means they saw it in a note, or did they see it on exam because of how the opening of the external cervix looked? But I would rest assured that that's not associated with any internal uterine scarring, and that is not something that I would personally be worried about at all. So hopefully this makes you feel better.
Hi, Natalie. New women's health nurse practitioner and provider here. I had a question on you have a patient coming in, they have regular periods, they have not gotten pregnant in the 6 months or a year, so you order, baseline lab work, you check to see if they're ovulating, order the semen analysis. I would like to know more specific data on what you recommend imaging-wise for the female. I know it kind of depends on history, maybe past STD infections or whatnot. Do you automatically order a pelvic ultrasound, an HSG, and then go from there? Do you also automatically check a sonohyst or an H-scope or something else? Like what do you do kind of baseline, and then do you do all the imaging so you have all the answers, or what? I hope this made sense. Anyway, thank you so much.
I just want to say I love this question so much, and thank you so much for asking. And to everybody who is also taking care of women, whether you're a nurse or a nurse practitioner or a PA or a physician or in any line of healthcare that really does work with women, especially those of reproductive age or when it comes to fertility. Thank you for listening and learning and asking questions, because I can't take care of everybody, nor do I want to, but knowing that I'm helping you take care of people means so much to me. What is my normal female anatomy evaluation? Well, I'm glad you asked. In every single patient, I do a pelvic ultrasound. Period. The end. I don't care if somebody else did one. I'm doing it. Why am I doing a pelvic ultrasound? Number one, I'm going to look at the ovaries. I'm looking at the ovaries to get an antral follicle count. I want to count the small fluid-filled follicles, see if that correlates with your AMH or your age. That piece to me is really important. Number two, where are you in your cycle? And does it look like that on ultrasound? Do you have a dominant follicle? Do you have a corpus luteum? Does that make sense with what your tracking is telling me? That's helping me understand the interpretation of your cycles. Number three, do you have any cysts that don't make sense for where you are in your cycle? Do you have anything that could be a sign of endometriosis, like an endometrioma? Are your ovaries stuck in abnormal positions and they don't move around? That's a big red flag. Fallopian tubes are not seen on pelvic ultrasound unless you have a dilated fallopian tube called a hydrosalpinx. So if I see one, I'm definitely going to make note of it. I'm always looking in the area between the ovary and the uterus to see if I see that dilated tubal structure. But typically you can't see that. So absence of tubal structures on pelvic ultrasound does not mean everything's fine. I'm also looking at the uterus. So what's the orientation of the uterus? What is the lining? How thick is it? Is it organized? Where are you in your cycle again? Does the lining make sense? Do I see irregularities that could be concerning? Anything like fibroids, polyps, adenomyosis? So that's a lot of things. And then I'm looking at uterus structure. Most people, this is pretty straightforward. You have a normal looking uterus, but in a sagittal view, do I see any division in your uterine canal? Did you have a septum, a bicornuate uterus? Just looking for any signs. So that pelvic ultrasound is it's like my stethoscope when it comes to fertility. That's giving me so much info. From there, if you are trying to get pregnant and you're coming to me for a fertility evaluation for infertility, meaning I've been trying to get pregnant for a year and I'm under age 35, or I've been trying to get pregnant for 6 months and I'm over age 35, I'm ordering an evaluation of the tubal anatomy. That is with either an HSG, which is an X-ray test, a hysterosalpingogram, or I'm doing it myself and I'm doing a FemView, which is a bubble test that we use in the office. The bubble test, the tests are similar. In both tests, speculum goes in the vagina, a small catheter goes to the cervix, dye or water goes into the uterus, and you evaluate it with either X-ray or ultrasound. In the bubble test, you then push air bubbles through the water and you have to watch them come out the tubes. I think all my nurses, everybody who works with me will say, when the tubes are open, you see the bubbles. It's so obvious. It's so easy. So you see them, they're open, easy peasy. If you don't see them, it doesn't necessarily mean they're closed. Things like pelvic shadowing and anatomy can just sometimes make it hard to see. So that's a test that is much better for the uterus, but not as great for the tubes in everybody. HSG is the opposite. It's really good for the tubes because it can really show their structure, but it's not as good for the uterus. It's just going to tell you filling defect, but not give you any more cohesive information about what that means. But if you're trying to get pregnant, having infertility, I'm ordering one of those two. If you are going to do IVF, you are older, you've been trying for a long time, you have a genetic disease, the sperm's not great, some reason is pushing us to IVF anyway, I'm not doing either test. The pelvic ultrasound's enough. I don't need to evaluate your internal uterus or fallopian tubes at this minute. I will evaluate them before we do an embryo transfer. But in my mind, there's no need for me to evaluate that now, do IVF, and things can change in 5 or 6 months before I put an embryo inside. So I'm going to evaluate that then. If you are coming to me and you want fertility testing, but you are not trying to get pregnant, okay, gosh, what do we do here? Okay, what do I do? Get a good menstrual history. Are your periods regular? In everybody, AMH blood test, pelvic ultrasound, all the things I said. If you have any irregularity to your periods, drawing out more reproductive hormones, looking for PCOS, thyroid disease. If you have a history, chlamydia, sexually transmitted disease, pelvic infection, abdominal surgeries, ruptured appendix, or signs of endometriosis, pelvic pain, especially when you're younger, pain with intercourse, GI symptoms when you're on your period, then I'm going to recommend that we do the HSG test before you're trying to get pregnant, because that might totally change your mind. Meaning, if you know your tubes are blocked and you're 25 and I can't unblock them, and you're trying to debate, should you freeze your eggs? The answer is an obvious yes, because you're going to need to do IVF to get pregnant. And it's so much smarter for me to get eggs out now versus waiting. So those are times where that's really shared decision-making with a patient. If they're just starting to try to get pregnant and they haven't really met the infertility, I usually review risk factors, offer it, but that's not always a hard pass for me. But if you're having infertility, it is part of the fertility evaluation. I don't tend to jump right to hysteroscopy, that's camera inside the uterus, or laparoscopy, camera inside the abdomen, anymore at all. I think we have really good radiographic options, and I think that that's just, ultimately less risk, and in talented hands, you're going to get really good information. That's not to say that's wrong. Surgery, looking with your eyeballs, is always going to be the gold standard, but obviously it costs more money. There's recovery time, no surgeries without any risk. And that's just not my preferred way to evaluate anymore. I hope that answered your question, and I have loved sharing this time with you. Again, guys, thank you so much for calling and leaving the questions. You make the show possible. So you can call and leave more questions at 657-229-3672. Again, that number is 657-229-3672. You can also follow along on Instagram at nataliecrawfordmd, and you can watch along on YouTube. Thank you, friends. Thank you all for listening to As a Woman. It would mean so much if you could rate, review, and follow the podcast to be notified of new episodes every Sunday. I hope you learned something new, and I hope you share it with someone in your life. Be sure to follow along on Instagram at nataliecrawfordmd, and check out the YouTube channel Natalie Crawford MD. If you're interested in becoming a patient, you can also follow Fora Fertility. I'm so thrilled to have you here, part of the community that amplifies others as a woman.